Obviously, you need to decide depending on the expertise in your unit and your preference. I mean, the question is, I mean, will the use of sedation make you give additional breaths to the baby if the baby goes apneic or has a chest wall rigidity? Because fentanyl, for example, can lead to chest wall rigidity. If you have inexperienced team using it where the trauma is going to be more, you can consider, but have a backup to support the baby's breath more. So in these cases, you can intubate the baby with a smaller ET tube and give the surfactant and extubate after a few minutes. So you're not exposing the baby to hypoxia or complications. At the same time, if you have a very experienced team who is going to use an angiocath or a surfcath, for example, it's reasonably okay. You can give cuddling, sucrose analgesia, and do the procedure quickly. As he explained, it's 30 to 60 seconds, and you might lose more in terms of the lung benefit if you give sedation and you have problems. So it's not hard and fast. You need to make an individual call. Be sensitive to pain awareness. So be aware that whatever you can do to minimize pain, developmentally friendly care, use of sucrose, and any other aspects of it that can be suitable without affecting the baby. So that's the key there. I mean, and your experience would matter, the team. And video laryngoscopy has come a long way in helping many units. So it's not readily available in many units yet, but it's coming up, and many studies are coming up encouraging the use of video laryngoscopy for minimally invasive surfactant. Again, there is about, if you watch Peter Davies' lecture, for example, he talks about 10 to 20% chance of the surfactant going into the esophagus when you are not actually visualizing, because it depends on the skill level and the confidence level of the intubator. So in a country like India, where expense plays a big role and you don't have insurance covering surfactant, for example, wastage of surfactant in that way is serious. So again, following the traditional way, you can confirm the ET2 position with the calorimeter. Again, I was discussing with colleagues during the course that even the ETCO2, the calorimeter is not available in India in many places. So that's another challenge. Here we have started using calorimetry even with the surfcath. So you can use a 3-size adapter to fit on it, and we can confirm the tube position before we give the surfactant to avoid the wastage. So these are all points to consider when you consider.
To add to that, doing LISA is a kind of a learning curve in the neonatal unit. It takes some time for everybody to get used to it. But then after some time, it just becomes very easy. And all the registrars, when they're tuned in, they start doing it. The nurses also are able to help well. You should see this publication from Calcutta, the uh, Government Medical College from Calcutta. They have been successfully last 5 years doing LISA, of course, using a feeding catheter, which has been slightly frozen and then thawed, so that it becomes a bit stiffer. And they've been doing it very, very successfully. We also use the feeding catheter 5 French gauge, and it's been doing well for us. But then now with the cost of subcat probably going to come back now to very lesser amounts. Hopefully, we should use more and more of these catheters. And the other thing is the video laryngoscopes have become very cheap and very inexpensive in our country as well. And probably some of you can look into it. When you go to conferences, you can see the stalls. There are video laryngoscopes that are available.